Hi, everyone, and welcome to another episode of the Rehab Podiatrist podcast, conversations that change and challenge clinical practice. Today, I wanted to have an episode, and I've invited a guest on to talk about technology, specifically in podiatric practice. The use of technology is something that kind of takes on, in some ways, and in some people's minds, like mystical qualities, or that it has all the answers, that technology and advancements in technology is exactly where we need to go. And it's kind of an evangelical approach to its use and its application. And as someone who uses a lot of technology, I agree there's a lot of really great things that come about from using it that pushes our practice forward. But I think there's a number of pitfalls to it. There's a number of ways that we can get too far ahead of ourselves and the research, and saying and doing things with it that may not be as supported. And so what I want to do is get a guest on to talk about this and just go through what we use tech for, what can be fantastic ways that we can use it, integrate into our clinical practice, what do we see as useful, and not so much demonize sides of it, but also just talk about what is the current really state of play and what we can say, can't say, what we can do, can't do, and sort of highlight some of the promising aspects from a purely sort of really clinical standpoint. What are people using it in the clinic rather than, in a research setting where sometimes maybe the tech is definitely a bit ahead from what we can get commercially. So that's the discussion we want to have today. So I'll introduce my guest who's very kindly given up his time to have a chat. It's podiatrist Darcy Dore, and I'll get him to introduce himself. Thank you for coming along.
Thanks very much, Alex. So my name's Darcy. So I've been a podiatrist since about 2015. I studied in the lovely border town of Albury, New South Wales. Since then, I've been working in private practice, mainly with a focus on musculoskeletal cases. I started my career in Melbourne with a pretty big, larger sort of podiatry group. During that time, worked with closely with a podiatric surgeon, and then from there, worked in sports physio clinics. Had a couple of good mentors there, which was really fantastic, and sort of developed my interest from there. In Melbourne, sort of during COVID, I got a little bit had a lot more time on my hands because employment was a bit affected. So I went back and did a little bit of postgrad in sports medicine, which was really interesting, and also bought a point of care ultrasound. At the same time, started sort of running a lot, getting into sort of endurance sports and trying to understand exercise physiology as much as I could, which was really fun. And luckily for me, those things did seem to complement each other. Since then, sort of moved to sunny Brisbane, which has been really fantastic. I wish I had done it sooner. And been practicing out of FootFaults podiatry clinic here locally. So we've got the podiatry element to the business, and then also we have a RunClinic element to the business that I sort of lead with my employer, Justin Holt, who's a great fella. So pretty lucky. A good chunk of my day is sort of helping runners of all abilities try and reach their goals. And you do use quite a lot of tech in the current role, which is really great. And we'll get on to the pitfalls, the challenges, but also really the profound benefits in terms of clinically, and then try to sort of being able to formulate treatment plans, execute on them, and feel satisfied in your own work, I guess.
Yeah, that's such a good point as well, that there is so much benefit, but there can also just be how it enhances just your enjoyment of your job.
Yeah, I think so.
But very much practicing clinical MSK, seeing a sort of a good variety of people and runners, and also the ability to see some runners as well. So it's a good focus, good area you've found yourself in.
Yeah, it was a lot of fun. Did take a bit of a while to get there, and definitely a lot of extra study in a lot of different areas, and time spent outside clinical work, really just trying to own different skills and learn as much as I can about about sort of things that interest me, which turns out to be quite a few things, which sort of fortunately and unfortunately at the same time.
And a well-used COVID break as well, not just sitting around watching Tiger King.
Yeah. It's no, it wasn't going to let that beat me. Just tried to hook in.
So you mentioned point of care ultrasound as sort of one of the sort of key technologies. What else does the clinic offer, and what do you use now?
Well, maybe from the very start of my career, when I was working for that large pod group, we was exposed to quite a lot of technology, even there, pretty much from day dot. So we had the Shockwave machine, which was pretty hot tech at the time, sort of 2015, 16, and 3D scanners, and also some gate plates, some pressure analysis plates, and a FoCUS laser, which we did different little procedures and surgeries and fungal nails and things on. So from early on, I was exposed to a lot, and trying to integrate all of that in and sort of sell a treatment plan, and was challenging initially, especially when you're just trying to figure out how things work as a young practitioner. It was definitely helpful, but I don't really know life without tech at the moment. What I do have, so the key things at the moment, we've got the Zebris sort of instrumented treadmill, which has sort of something like 7,000 sensors in the belt, with some slow motion cameras from posterior and from sagittal. So this is probably my most valued piece of technology that I'd use the most in a day-to-day clinic at the moment. It's just really helpful to have a hypothesis about what you think is happening, and based on your screening of the anatomy and the mechanics so far, and then have the person walk and really just get this sort of real-time feedback about what's happening, where the load is going. It's pretty helpful for pattern recognition, where what you see in the screening can match then what you see in the the data that comes out of the machine, and also just things like, say you have an orthotic and you're expecting X, Y, and Z to occur, or a new shoe, or whatever it might be, or how maybe barefoot compares to, say, the shod condition, and it is just really helpful to be able to have a hypothesis and test it really quickly and get a lot of objective data back on what's happened. So Zebris being sort of very powerful. The other things we do have is the Shockwave machine. So Shockwave machines obviously vary a lot in their, from the radial machines to the extracorporeal focused machines. The efficacy seems to sort of differ from one to the other. How they're used, the type of head that you use, the frequency, all of these things. So with Shockwave, I think there really has to be very strong clinical reasoning as far as what you are actually trying to achieve with that tissue, to be able to sort of best guide prognosis. And I think all that does come down to diagnosis and clinical reasoning with the Shockwave in particular. Do you have a Shockwave machine?
I don't currently know. I find I refer off for a lot of when I feel like Shockwave's useful, just because it's one of those things. I guess I'm in a smaller town, and you've when you get one, it's a big investment, and you've got to be seeing quite a few people, and it's sort of not hit that zenith yet, where I feel like there's a use case for the amount that I feel like I would use them for, or how many people I refer off for it really. It's interesting because I guess you sort of highlight there's two sort of groups of tech that you're sort of looking at, like a diagnostic sort of tech and a treatment tech. And I guess you would look at like the diagnostic tech, and one of the things that you said for the Zebris treadmill specifically was that it was a hypothesis test machine. Like, it's really cool to be able to go, this is what I think's happening, what is actually happening, this is what I think's going to happen, this is what actually happens, and recognizing patterns, which I thought was a great way to sort of think about it. When I've talked to biomechanics researchers, they sort of pressure analysis is a funny one for them, because they turn around and they say, well, it's actually not really good because it's just a blob of data that we can't use. They prefer force vectors and other sort of elements. But one of the things they did say is it's like, oh, it's really kind of more of an outcome measure, which I think is actually like a perfect encapsulation, exactly what you're saying, which is it's looking to see what the outcome is and it's contextual to what you're thinking, rather than being something within itself that will tell you all the answers. I guess is that a good sort of understanding of how you consider and use it?
Yeah, I think that is essentially how I think about it. The other thing that does relate into that as well is that when talking about pressure data just being not as helpful on its own, with a really good eye, considering that the slow motion video does synchronize across, you can sort of overlay those joint moments and force vectors, even though in a more subjective way, to the pressure data. So potentially just the way that researchers collect data for certain things, might be different, and then particularly if they're not in a clinical setting all the time, those patterns. If you're trying to, measure very specific things related to a specific thing, you may sort of miss the forest for the trees in some senses. But yeah, I would agree with the general sentiment about hypothesis testing.
Yeah, I guess that's exactly the thing. Is the researchers are looking for verifiable data. They don't want subjective data. But I guess that is the difference between, when we look at population-based studies or larger sort of groups of studies and a large amount of people going down to the individual, you are sort of looking for, this is the individual, this is what I'm seeing, it's kind of what I think's going on, and you do get that ability to test. One of the things I've heard is people do a large amount of biomechanical analysis on the Zebris itself, not just walking, because they get to use the pressure plate with those individual pressure sensors, that then they can see what's happening across a large amount of different movements, squatting, calf raising, that sort of thing as well, rather than just the data from walking and running, which is kind of an interesting shift from when you think about just force plates, which again are measuring force and force vectors, not pressure. So they're only really telling you how much force is going through and maybe what direction, which is not what we see in force plates currently. Is that something that you'd also consider as well?
Yeah, I do resonate with the point. It does. I think sometimes in the research setting as well, the aim of research is to try and reduce many variables into something that you can form a conclusion about. So at times I think the complexity gets a little bit lost, and the nuance and the perspective of the individual in front of you. And I think that's why sometimes the research can come up with findings that don't really tell us a whole lot. And I feel like a lot of times that's the question that's been asked, which is just the nature of the job, right? But yeah, the other thing that I would point out, as I said, between the force plates, is that being podiatrists, being quite concerned in a lot of contexts about pressure itself. So the surface area with which the force is applied to. I think that the Zebris and the pressure analysis software having a very large advantage over force plate testing. Obviously, they're used for different purposes and different contexts, but a big part of the podiatrist role is sort of shifting load and pressure around. So I think that understanding where that goes with something that really accurately views pressure is helpful.
And I guess it all goes back to that point of being an outcome measure. That it's not there to sort of tell us how the foot works. It's just to tell us, it's more information to get in to tell us the impact of what it was before, what it is now, rather than drawing a conclusion, which is what research is trying to do. When you've got to build, build and build and build, and you've got to have very, very strong, small sort of bits of or areas of information that you've got to build and build and build, and it's got to be causally relevant and to build a bigger model. But really what we're trying to do is just achieve an outcome. So there's very much a different sort of set of goals, which I think fits quite nicely with sort of what you're talking about in terms of making a difference, and that complexity that we are dealing with everything in someone's life. We don't get the ability to shut out areas just to figure out how this little bit of the foot works.
Yeah, no, definitely. I agree.
Would you... It's an interesting thing. So I haven't used point of care ultrasound, and I don't have a machine. I haven't had much experience with it. I refer off to a radiology clinic to use to get the ultrasounds and all the different bits of radiology. How do you sit with POCUS and using it in your clinic? And I'm thinking specifically how it would potentially differ from a Zebris, because I think one way I'm thinking about is it more information? Does it replace radiology, or radiology referrals? How to use them? What do you think?
Yeah, it definitely doesn't replace radiology referrals at all. So there are times where the examination required an ultrasound, or the diagnosis that you expect to come up with is something that you would like the radiologist to come from a radiologist as opposed to yourself. So, and I would often use the ultrasound as something to send for an MRI. So use what I find on the ultrasound to increase the likelihood I'm going to send for MRI, or significantly decrease. The POCUS in itself, it's a pretty big undertaking. So, you have to spend a few hundred hours of your own time sort of researching, practicing, trying to, get certifications, and just really going very deep on the anatomy. But I would say it has revolutionized the way that I do practice. Definitely from the perspective that once you do get super duper deep into anatomy and you can sort of see things, how they relate to other tissues in an image that if you're sort of moving around from different axes, you can essentially see in 3D, and it's something that you can appreciate the anatomy so much more deeply than viewing diagrams and things. So from that perspective, and then also from a physiology perspective, watching, for example, edema settle down or over time, or watching, a tendinopathic structure sort of slightly change and over time is also quite interesting. Like, for example, the paratenon might shrink significantly in an Achilles, where the actual tendon itself might stay, sort of roughly the same, but there might be some slight changes to the thickness, as the person progresses in a positive way. I find that all quite interesting. The other thing I find it really helpful with is just for basic procedural things. So helping with nerve blocks, helping with injection therapy, and using it in a practical way. The other thing as well is that it is a lot though. You can't, you have to obviously understand your limits with it. So, you're not trying to diagnose vascular problems yourself. At times, I don't give people very firm diagnosis, because that sort of does lead into a slightly grey legal area. So medico-legally trying to also be careful, and then essentially communicate with patients as I would any other time about pathology and anatomy, being very sensitive about not creating a nocivic effect, talking about X, Y, and Z tissue and the state that it's in. So and definitely just understanding the limits and referring on as you need, because it is a tool and you still need all those other modalities.
I like that response a lot, because there's a couple of elements. One is that you're getting a much better understanding of anatomy. You're probably going to get a much better understanding of anatomical variation. You get to see what's happening on the top, and immediate correlation, but it's not something that, to think about it in the same way they talk about the Zebris, it's more information, but it's not something that and it can be an outcome measure maybe in some respects, but it's not something that's replacing your examination in a way. If anything, it's actually just enhancing the way that you see things, and also maybe instilling some timelines. You can start to see patterns again on the ultrasound that you wouldn't see if you didn't have that. Is that kind of an encapsulation of how you use it?
Yeah, I'd agree. I think what's that good saying? If you shut up and let the patient listen, they will tell you the diagnosis. So I'm a big fan of that saying, and I'm really, a good 80% of the time I've sort of, after I've asked all the questions in the history, I like to be pretty detailed with that about, the pain sensation, how long it's been, what's it like when you move, what's it like when this happens, and so on, and then understanding where the load goes with the Zebris, that you can, really increase your confidence interval in your own diagnosis. But the way I like to think about imaging is that you're essentially, so you're walking into a room, say you've got a cake baked on the bench, and everything smells lovely. You could think about the aromas and the taste as like the chemical environment of the tissue, and you could think of what if is the cake sort of fresh, or is it old and hard as maybe the dynamic elements of the tissue. And what you're doing with the any form of imaging really is you're just taking a photo of that object in space. So you're not really getting all of the qualities that exist at that time with the tissue on just the image itself. So I think understanding that, knowing the limitations, really does help, because then your other clinical reasoning skills about understanding what the pain is like, how sensitive is this person, is there like hyperalgesia around which would suggest an acute inflammatory response, and these type of questions and ideas kind of dictate how you perceive the image that you've got, and contextualize it within the overall assessment.
Because it's something interesting that I'm seeing sort of on social media and in different places, is that once people get an ultrasound, everything gets ultrasound, and then everything kind of goes through this filter. Oh, can we diagnose a fracture on ultrasound? Can we do this? Can we do that with it? So specifically, like with the ultrasound, it's interesting. You're talking about it in a very contextual way, and that it sort of fits in your practice. And it's kind of an interesting contrast, because you're spending so much time learning about it, but it might only actually form a small part of your practice, and the impact is kind of much more. It's not linear. It's not the amount of time that you're spending on it. It's quite logarithmic. Like suddenly a small amount of time spent on that kind of just confirms everything, or opens up more questions, or just kind of helps you learn more about your other skills, rather than being the skill in and of itself that you're kind of trying to market and push.
Yeah, I think that's a great way to describe it. That's pretty much exactly how I think about it, really.
Which is interesting, because I guess if just staying on the topic of diagnostic, or more of that tech that's used in the diagnostic sort of side of things, we see a lot of marketing around technology. Oh, we have this, and oh, we have that, and in some ways, we see a lot of people will sort of use it as almost like a selling tool in a way. Like the Zebris, I think, is right for it, where it's like, oh, we whack something in your shoe, and oh, look, everything's changed. And you sort of made that point there, that it's an outcome measure, but it's an outcome measure that's measuring pressure. It's not measuring tissue hyperalgesia. It's not measuring like all these sort of other aspects which relate to someone's pain. I guess, how do you go about marketing it that sort of sits well with your use of it? And how do you see other people do it? I mean, no names, no nothing, but how do you see some pitfalls potentially in the way people market it that might not sit with the way that you're practicing?
Yeah, I'm not really involved a lot in the marketing element to our business, but the Zebris certainly does feature heavily. I think that when people do view that on the website, I think they do want to come in. They do get like a sense of, oh, this place must be, highly professional. They've clearly invested in, the technology to help their patients and so on. I do think that maybe with Zebris less frequently, just because there's really not that many of them around. Like in Southeast Queensland, there's a small handful, if that. And I guess there's only so many promises you can sort of make with something that just sort of has a look at force and pressure. I mean, like athlete's foot essentially have a system that was designed by Zebris, and people see that. So they, don't get me wrong, though, I think people do really gravitate towards it. Like, I couldn't tell you how many times people have come in after walking on the Fitzy system and Athlete's Foot and just saying, oh my God, how good was it? I got, my foot shape scanned, and then I got a shoe selected for me. How good is technology? Which obviously still occasionally, will bite them in the bum a little bit. But I think maybe more with marketing and issues there, potentially, I'd probably say I take more of an issue with either maybe Shockwave marketing sometimes being sort of the cure-all treatment, and then probably orthotics being the next one. I'd probably take more an issue with marketing in those two, really.
That's a good point. So from like a diagnostic perspective, I guess that's very true when it comes to marketing wise. It's just getting more information. But I guess in terms of, if you're like, let's say a clinic and you're like, I want to get a Zebris or I want to get a POCUS and I want to start using this tech all the time, you can't rely on that technology to change things. You can't expect to get a Zebris treadmill and then that's going to save your practice in a way, because what you highlighted it was the professionalism, it was the investment in technology, it was people getting the sense of how you practice, and the Zebris and the POCUS was kind of like an output of that. These people must be, because they're spending this money. But would you say that if you didn't deliver on the other aspects of practice, that it would be as successful?
In the first role that I had with that larger company, there was a high proportion of pretty new graduates, myself being one of them, and a very, very heavy marketing campaign that essentially, we know everything and we can fix everything and we have all this technology and we can do, amazing things. So I did find that a challenge, because what the website was reporting and where I was at a practitioner and how comfortable and familiar I was with this technology, which was relatively new, I found that to be a challenge. So I definitely have experience where it didn't go perfectly, and patients did have high expectations, and my clinical reasoning skills at that point were not mature. I was just come out, and so I could see how it would not go that well. I guess it does depend on what who the clinic is made up of and the mentoring that is there. And also, say for example, somebody did buy a Zebris, say if it was three podiatrists to a business, and potentially those pods might actually learn a lot about how things move and start to recognize those patterns, be able to test these hypotheses, change their tack, try again, and actually have more success the second time around. So I could see how that would enhance outcomes over time, just through the practitioner learning more and getting better.
Yeah, I like that in that way. It does open a can of worms. It goes back to that point where we're getting more information, more data, and if you're not trained in understanding how you do it, you're not going to deliver that. And in a way, you set yourself up for higher expectations. I always think of, and the way that I like to think of my clinical practice overall is under promise, over deliver.
Yeah, certainly.
That becomes more difficult when you have more tech and they're going, well, you can do more. So you've got to kind of back that up. So in a way, you've got to practice and you've got to learn with this sort of tech and build up confidence. So in a way, it's probably not good to go out and as soon as you get the tech, market it and think it's going to change everything. There is a steep learning curve, I guess. Would that be kind of what you're thinking?
Yeah, I think it depends on a person, but yeah, there could potentially be a steep learning curve. Trying to fit it all in can be a bit of a challenge as well. So, for example, the person comes in, and at our clinic we've got essentially slots of time for MSK. So it could be a 30 or a 40 or 50 for some of the running analysis clients, and trying to choose what we do in that time. Like, we haven't even touched on the anti-gravity treadmill that we've got, or even the gym, which is sort of not maybe technology in a sense, but it is a treatment option. So they're definitely, it is complex trying to prioritize what to use at what time, and I can imagine that some people would struggle with that. But for me, I guess it's a good problem to have. It is really quite. I think I've got the hang of it now. Trying to fit it all in, and we don't charge on top for any of these things. We just do charge a premium that is built within the consult, and it seems to be working quite well. We're always quite busy. I find that with that, charging slightly higher as well, and offering what is essentially a premium service. If you sort of do look at to some of their competitors, I think I can say that. Then there is a better ability to actually sort of maybe under promise, but then to really deliver more frequently than other times.
That's such a good point, because that was my very next question. Like, how does this feature in to your clinical practice and billing? And I think that's such an interesting way, because in a way, then you're not having to sell it. It's the selling is on the way in, where it says, this is our price, this is what we are. The website's selling you, your referrals are selling you, everything else is selling you. And then the tech is, like we said, an outcome of your professionalism, of how much you're investing in it. And you then don't have you don't have to sell something and say, I would like to use this. It's an extra $15. I mean, it sort of feels like a McDonald's. Would you like fries with your appointment?
Yeah, and that's how we operated initially. Not we, as in one of my first jobs in Victoria, and I did find that a little bit difficult. Like, for example, at the moment when I'm using Shockwave, I see it partly as trying to deliver the Shockwave treatment and the adaptations that we'd like to see from there, but also I might have 3 to 5 opportunities to deliver education, to deliver rehab exercises, to deliver load management, to deliver pain education, repetitively over time as a person's in this acute or subacute stage of their injury. So I think that the time in front of the person is really valuable. So charging extra, the McDonald's fries with that type thing, I don't like as much, because really what I want is the person to come back so I can talk to them and guide them through the treatment plan, not just to sort of deliver Shockwave. So as another way of thinking about it, the Shockwave and getting a person to sort of come back in 5 times in 6 weeks is also 5 opportunities to do all those things I mentioned, which are so obviously super critical.
I guess moving into some more of, like, because we're kind of naturally drifting there, sort of the treatment side of things, the tech, the Ultra-G treadmill, the Shockwave is sort of probably the two big different ones that you have and use. That's such an interesting way to sort of focus on it, because again, yes, you're not selling a treatment, you're sort of, it comes in as part of it, and it's, when you're using it correctly, it's a way of creating more of those opportunities. And then it sort of falls back again on your clinical skills and your communication skills and all the other aspects, your ability to provide rehab, your ability to understand where that sits. It's not a case of you coming in to just get whacked with the Shockwave, which is I guess you've hit the nail on the head. What I sometimes see, and sometimes also see in the marketing, is a case of it is the be all end all treatment, and you're going to come in, you're going to get it, and it's going to be helpful, or at least that's, whether that's intended or not, sometimes what I see the implication is, and some people I definitely see for second opinions that are like, I feel like I've had a lot of stuff done to me, not with me.
Definitely, and I do agree. I think it does all come back to then at that point, like you said, the clinical skills sort of do have to be there to have good results with any technology, really, and trying to really understand the diagnosis in a deep way is important. Something I do frequently see either with Shockwave, say it's plantar or posterior heel stuff, like the amount of sural nerve entrapments that just get labelled purely as Achilles insertional pathology and just get whacked a heap of times, where there's very clearly a lateral burning, radiating pain that is not consistent with what an insertional tendon feels like or behaves like in under load. That thing getting whacked, and it's not going to feel, that nerve is not going to appreciate getting whacked with a shockwave. It's not really the tissue type that responds to mechanical vibrations. And similarly in the plantar heel too. So really, if a person doesn't understand that in that acute inflammatory period where the nerves are hypersensitive, that's not a time to start shockwave. A lot of the time, it's too early. You're going to worsen things, and the idea that you're going to make things better at that point is a bit silly. I do find that it's interesting to see what some people will come in and say they've had shockwave by a chiro or a physio, and say, okay, so what was their diagnosis? And people are like, I don't know. They sort of just said, this is doing that, and therefore it has to be whacked. So it's interesting.
It's funny because there is a study that just came out that I think of, and it makes me we wonder as well about a lot of things that we do. But it was by Ebony Rio, Miles Murphy, and it looked at Achilles tendon pain, and was saying that actually the way people report it is different to what they actually diagnose when they load it. So it called into question a lot of studies that previously just used reported pain location and an ultrasound. So they said, well, actually, they need to load it. They need to prove that when they load the Achilles tendon that it's sore, that's actually what's happening. And so I think that's such a good point, and sort of fits quite nicely with the research. We see this with huge major diseases like hypermobility. We were just chucking everyone and anyone that had was slightly bendy into a study, and what do you know? We got highly variable outcomes because you're taking someone who's bendy and someone who's got a genetic tissue, connective tissue disorder, and you're putting them together and not seeing the same outcomes. And I think that's kind of what you're getting at. You're seeing people not narrowing in on exactly what's going on, which I guess when you're thinking about tech, that sort of goes back to the original diagnostic tech of having more information to be able to determine, and then also I'm guessing see patterns with how people respond to something like a new treatment like shockwave, so you can be more targeted. And I guess that's kind of what you're getting at. You're trying to be very targeted rather than spray and pray, really.
Yeah, I'd say in everything I do, I try to be as specific as possible, which gets to be a little bit ridiculous when I'm writing my notes, to be honest, and then trying to tell somebody about this thing that there's so many little pieces of information that relate to what I think is going on. But I do find that as I do that things are a lot more predictable than they ever have been for me anyway, which is helpful.
So how do you go about, if you take a patient that you think, okay, shockwave's going to be helpful for, but we don't have in all cases strong evidence to say they're always going to be responsive or it's going to work. How do you have that conversation about something and say, look, we're going to do this. This is, how many sessions we're going to do. It's obviously going to come at a cost, and it might not have a good outcome. How do you find that you have that conversation? Or are you finding that because you have all of this other information that you're collecting all the time, that actually it doesn't, you feel more confident with being more confident in explaining how it's going to work or what it's going to work? Like how do you navigate that now?
I think going in with a sort of subdued sense of confidence is always good. I like to not celebrate the wins too much or commiserate too much on the losses. So as soon as something isn't working out how I'd like it to, I would try and revert back to, is my diagnosis correct? Is there something going on load-wise or medically that is creating this unpredicted response? And then I just sort of be radically honest with the patient and just say, look, we're 3 shockwaves in. I would have really liked you to be 15 to 20% better by now. potentially something else is going on here. We've tried to control all the variables that we can. In my initial understanding of what was going on with your foot or leg, this is just a little bit outside what I was expecting. So maybe we need to look at X, Y, or Z. Maybe we just need to push on. Maybe we need to sort of further take down your load. And I think I'm just really, really honest. And I think people really are happy to be not sold anything or sold a dream or overpromise anything. That radical honesty I find to be the best way.
It's interesting.
People respond pretty well to that too.
Hmm.
People are just like, okay, well, look, you tried, you tried as hard as you could, and it didn't work. Maybe we do need to look at something else.
It's interesting that you say that, because that's kind of how I look at clinical practice, and I look at treatments as well, just overall, that it's another opportunity to gain more information, gain more outcome, whether that's doing something, then looking what happens on a Zebris, or just looking at something and someone coming back with an outcome measure, that you learn so much more about it. And that's kind of exactly what you're sort of explaining there. But it's also funny because when I think about how medicine operates and how hospitals operate and how really every other sort of form of medicine operates, is they don't go in looking for the hard diagnosis and going, this is what it is, this is what's going to happen, this is how it's going to respond. It is very much a case of, this is what we think is going on, let's run a bunch of tests. Okay, we're going to trial this drug for a period of time. Rheumatology, they like trial this drug, then trial this drug, then trial this drug. Oh, we've learned actually it's not this rheumatological condition, or you're not a responder. Like, we don't have as much of that baked in. It's very much get the diagnosis, get the outcome. And it's funny because I feel like that is what infuses with technology in a way, because if we've got that mindset, technology is kind of almost a way of saying, well, we can't be wrong, or we've got the information to not be wrong. Is that sort of something you'd agree with, or something that you see?
I think just trying to interpret things in a way that's even though you've got maybe a high confidence interval for some things, just to be mindful that there is that percentage chance that you've misinterpreted something, or that there was something in the data that created something that you looked over, or potentially you were just really busy and human error came into the picture. You just didn't see something one day, and that just it happened to be a key piece of information that you actually needed to know and take into consideration, because we're all people, right? And I guess medicine's a fantastic example of where human error is a very huge source of problems within our health system. As much as people sort of for the most part have the best intentions, we're only human, and I think it's no different there.
That's, yeah. As someone who has a second podcast that talks all about how clinical practice affects us as human beings, and we're not always at our best, and how we do that, like I very much agree with that sentiment, that we're not robots and not machines. We are doing our best. And I guess that yeah. Do you find that having technology with more objective data makes it easier to not miss those key things, or because you have, on the treatment side of things, you might have a tech that gives you more opportunities to see someone just the way that it operates, that you're finding that happens less now? Or are you finding that actually we have to be aware going in, there's actually now so much more we need to be aware of, and it actually can sort of, you miss the forest for the trees?
Yeah, the objective data with the technology is obviously super helpful, but say, for example, you're following a treatment plan, the objective data that becomes important after that first two consults is how the person's going, what are they doing, how are they doing their exercises, how many steps did their Garmin tell them that they made, like what was the intensity like on their run compared to the week before. So I think maybe collecting objective data makes you hungry for more objective data, and that just comes into other areas where you're just trying to get pain scores and understand how many steps people have taken and so on. So I think, just getting hungry for different types of objective data.
Yeah, there is a great study, or not a study. It's a I think it's a commentary or an editorial piece, and it's outcome measures measure outcome measures. They don't measure like patient improvement or it's something along those lines. And it says exactly that it's it agrees exactly with that sentiment that when you collect more, you just want more. But we've got to ground everything that we're doing in how is this changing and helping the patient. And I guess is that something that you maybe think of? Do you think about how is this going to change what's happening? How's this going to improve something? Or is that sort of just becoming a bit more automatic now that you know the tech? You sort of go, I see someone, I see this problem, I've seen these patterns before, or I see that I'm missing this piece of information that would change it, and you just kind of go into autopilot, or are you still consciously thinking about how you use things?
I think that things are becoming more automatic over time, which is great. But unfortunately for me, my curiosity just pokes me into different things to try to collect data about and see more patterns. So as much as it is becoming more automatic, what it's actually done is free up capacity to screen and look at different things. So say if I become more efficient at X, Y, and Z, then maybe we'll add W in there as well to get W, X, Y, and Z, and that will give us me a slightly more overall picture. But that's probably a pathology on my part rather than anything else. But it definitely is becoming more automatic though, and it's I find it very helpful.
How long do you feel like it took before some of the things started to become more automatic? So if someone like picked up a piece of new gear and was starting to use it, and it might be different for different pieces of gear that you have, how long did you start to feel more comfortable?
I think it probably just depends where the practitioner's at in terms of the career. I think it took maybe 6 months to get really comfortable with Zebris, and I imagine if I had tried to use it in my second year out, it would have taken a few years. It's probably depends on the person. Obviously, the ultrasound is a very protracted process over at least a couple of years to feel a little bit more confident, and obviously still an amateur sonographer as well, might I highlight, compared to the highly qualified sonographers that exist, and some of those are so fantastic. You've got a radiologist who's also a sonographer, and definitely deferring to them for whatever we need, understanding the limits.
If we were to change tack and talk about the Ultra G, because I guess that's kind of an interesting sort of outlier in both a treatment, but sort of not a treatment. It's something that people use, but it's not something that's kind of producing the outcomes. It's kind of it's almost a piece of gym gear in a way. How does that fit into things in your practice?
I think it depends on the use case where it really can be a treatment. So, for example, the Ultra G we use a lot in people who have, say, neurological conditions, or have got, had a stroke, or a traumatic incident or something, where their capacity to load is so low that them trying to walk for, say, 500 meters might make them exhausted, or might give them such muscle soreness or an injury. So getting them on the treadmill at, say, 1.5 kilometers an hour with very little pressure on their legs, and enabling them to walk in a way that's not going to breach their current load capacity, and then just trying to very slowly, progressively overload that over time, or even just really try and maintain the capacity they've got. Like, for example, if someone has MS, and they're 60, they may not improve a whole lot after the first month, but if you can prevent them from deteriorating and get their musculoskeletal system to load, getting their cardiovascular system to be able to pump around, to enable their tendons to have more loading cycles and stiffen ligaments and all these things. That's part of how we use it. Definitely as a rehab tool for runners returning from injury, and sports people who maybe have had an ACL recurl or a total knee replacement. Just again in the same vein, to meet their load capacity where it is, and then trying to progressively overload that over time.
That's so interesting because I didn't expect that. But when you think about it, it's hydrotherapy without the water, but without the resistance that's created by water in moving. So it does it does recreate walking, but with less pressure. And there's like so many different groups in there that you're helping, not just when we think Ultra G, we think runners, we think people with stress fractures, we think people trying to run with less load, but it very much is something that actually is just a different way of hydrotherapy. And I can see a lot of those people as well would actually not be good candidates for hydrotherapy because, you can put someone who's, with a stroke, in a pool, probably not at that state where they're having to take so much load off them.
Yeah, it's specificity at the end of the day. The walking is the most specific thing to walking. So just helping them with that. But no, it really actually is quite amazing and rewarding getting some of the people with neurological conditions to progress over time just by enabling them to have something that A is specific and B is able to progress over time.
How does this fit into your practice? Because you said before your tech doesn't get charged as extra. Are you fitting this in as a consult and you there all the time? Are people coming in and using it?
It does vary. It does. It varies on the type and the caseload. It gets a bit complicated. That does. But yeah, sometimes people will come in and use it themselves unsupervised, and other times they will obviously need a bit more guidance, and it's a slightly different way of putting it into the computer and the system.
So I guess it's something we sort of haven't talked about with all the sort of tech, but this sort of brings it up quite a lot, is there's almost like a level of flexibility as a clinic that you need in terms of how people are going to use it, when people are going to use it, and specifically then with the Ultra G, almost like how being really adaptable around making decisions of actual use for people, because you'd have some people where you just need almost like book the Ultra G out for, and they'll just come in unsupervised. You'll have people that you run sessions. I'm guessing you're going to have to change how much you're billing and what you're going to need to do. So there's very much like being able to trust your clinicians and letting them make decisions for you around that.
Yeah, definitely. And we call our admin staff client experience officers, or CEOs for short. And they do have a lot of there's a lot of systems that have to be in place to enable that, and they do a fantastic job. So it is definitely a group effort to have it all running smoothly, which it does.
That's such a good point. And I guess when we're thinking about Shockwave and we're thinking about Ultra G, so the treatment side of things, the same sort of question we asked before, how do you go marketing wise? How does that, and I guess overall, how does that impact your patient demographics? Who sees you? Do you have people turning up saying, I'm here for Shockwave? But how's that all go?
Yeah, I definitely think so. Like, particularly with the heavy marketing towards the RunClinic side of the business, we definitely get a lot of runners specifically turning up for data analysis and advice, and definitely people turning up specifically for Shockwave for sure, and anti-gravity also. So yeah, definitely do get people coming to specifically seek those things out, which is why I think that there are definitely some advantages to large clinics trying to embrace things where they can, as long as the clinical reasoning is in there and the understanding of the limits of each thing is there.
Would you find that a lot of people will turn up and you'll turn around and be like, actually, you're not a candidate for this, but you are, we should be doing X, Y, and Z?
Yeah, that does happen every now and then. But I think just after having an honest conversation with the person, that's the best way around it. In saying that, where possible, I'll also try to be accommodative of their wishes so they don't feel like they've been rejected. So I think playing that one by ear, but yeah, it does happen from time to time. I try to keep people happy. You can always just turn it down and wave the magic wand. Just try to get them a bit of placebo potentially.
But again, I guess that comes down to that flexibility in terms of the staff members being able to, if you are in a clinic and you're thinking about it from an owner's perspective, I guess I always think of from an owner's perspective now. But yeah, if you're having it in your clinic, people need to be able to make that decision, and it's not so much a case that someone's going to book in for Shockwave, be interested, off it goes. There's going to not be like a course that you could potentially sell it as and go, you've bought a 5 Shockwave package because you might get 3 in and go, this is not working, and we need that flexibility to change. I guess that's sort of the way that you're thinking about it, is that it's very much a case by case basis.
Yeah, it is very easy for us to pivot. So I'll always try to get the person back, because again, it's going to be opportunity to educate on load and exercise and pain and so on. So if, say, for example, we weren't going to follow through with Shockwave, then maybe we'll spend the session in the gym trying to get form right, talk about exercise and so on. So yeah, definitely easy to pivot, and the good thing is there's always things to assess. So you can always, again, use the session as an outcome measure in a different way.
Have there been things that you are now getting more into, just adopting more technology and picking things up? Have there been things that you've been surprised by? I'm thinking more in terms of things that haven't worked, things that haven't been as effective as you thought, or haven't sort of panned out in the way that maybe it was sold to you that they would. I'm thinking, because we focus so much on talking about all these fantastic things and contextualizing it, but I guess to sort of focus in on, some people who might be thinking they're going to grab something and it's going to solve this problem. Have you had any of those experiences?
I think that Fox laser, trying to use that on the single nails was probably the biggest flop of them all. So yeah, my experience with that was every now and then it worked. I was always trying to get them to use a topical anyway, because I didn't trust the laser. And it was like exorbitantly expensive per session at the time, when I was using it many years ago in Victoria. So that was a huge flop. 12 weeks in, persons spent a considerable amount of money on this laser treatment for their nails, which are so dystrophic and heavily infected. And even if you sort of say to them, oh look, I don't think there's a very high success rate for your toes for this, I want to try it anyway. Okay, so that would be probably the most disappointing. And since that experience, I don't really try very hard with nail fungus. I sort of say, look, here's topical, this is the success rate. If you're eligible for the oral terbinafine, then that's something that you can do. That's something that I would suggest.
That's interesting, because it's almost, in a way, by having the tech, you sort of set up implicit expectations or ideas, and I guess you've got to be able to back them up. And I guess that's kind of a warning for just indiscriminately applying technology without thinking about its effectiveness, giving it time to sort of ascertain. Because I had the exact same experience with the laser, going, no, I'm just not keen on this. I'm not seeing the outcomes anecdotally, and I've now in successive years heard that as well. But I guess, would you agree that side of things, that you need to be careful about what you buy and market, because in a way, if people are going to turn up and say yes, and then even if you warn them, they go in, they can still be annoyed.
Yeah, I think choosing the demographic that you're seeing on a daily basis, and then trying to match anything that you buy to that is a very key point. So, for example, maybe the most hardened barefoot advocates may not suit getting a 3D printing orthotic machine. The people that are going to come in there are going to not be expecting orthotics. Maybe people who are seeing more elderly or community client base, we're not going to benefit a whole lot from spending a lot of money on a Zebris. I think just trying to match the device to the clinic is very important. That
sort of, you've predicted sort of, well, I'm sort of thinking about all the questions that we've asked and sort of what I've missed, and that was probably a big one towards the end, is that, yeah, you're not buying the technology to change who you're seeing, what you're doing, how you're doing it. You're doing it to enhance what you're already doing. So like if someone's going out to buy a machine or do something, you've got to have the demographic built in ready. You wouldn't be doing it to change your demographic.
Yeah, I don't know. I guess it depends on the business owner and the direction that they want to go in. Definitely see some businesses from time to time try to revamp the face of the business and do some new things. But yeah, I guess it comes down to the individual.
Yeah, I guess I would probably be prepared to sit. I can see you being careful and sort of going businesses, but I guess I having been part of been worked at places before that have done that, I guess I'm picking up from the conversation and what you're saying. I would be prepared to say that, but I can understand why you might be, because yeah, I can see business cases where if you're a larger business, you can make that investment potentially, but it probably comes at a significant cost that you're going to have to shift your business and lose a bit of cash there. But it's not something, if you're like a 95% GT clinic, you can buy and then a Shockwave machine, then start all of a sudden treating runners, because it goes back to that point that it's adding to you what you do already. It's not the thing that's transforming it, that alone.
Yeah, definitely. Yeah, it's it is tricky. It is tricky trying to change the clinic. I guess you'd need the staff to be on board. You probably need the location, need the branding, and then probably add in the technology as well. But I generally think it is good but I'm definitely about the podiatric profession sort of advancing in its in the services that it can deliver, and the treatments, and just to show the medical community and the public, that we really can make a big difference in people's lives, and we really can look at things, and not all heel pain is plantar fasciitis, and do we know a bit more than that? I feel like people trying to take on board new things, as long as they want to actually learn more and understand how it works, is great.
So if you're recommending tech to anyone, like, maybe that's a good question, is what tech would you recommend for what type of person? But that's kind of the general advice, that if you're getting tech, you're keen on learning, you're keen on advancing in that area. It's not something that you can buy and just use straight away.
Yeah, definitely. You really want to have explored that thoroughly, and obviously return on investment is really important. Really needing to make sure that you can return on that investment. But yeah, at the end of the day, definitely more for people, trying to just help people in as many ways as they can, and make a profit doing so.
We've stayed away from that profit side of things in the discussion. I think that's a sort of fantastic encapsulation in terms of thinking about tech, because where I started with the premise was kind of looking at more of like, okay, we're hearing all these things, doing all these things. What is the downsides of it all as sort of a starting point? But I guess being someone who's using it all, you're very enthusiastic, you're very about it, and you can sort of explain it more in that positive sense of, this is where I'm using it, this is where it's great for, this is all the good things that come from it, and how we sort of put it in. On any sort of, I'm thinking about finishing thoughts, is there anything out of the things that we've discussed, or maybe things that we haven't discussed around this conversation, that you would want to put in or would want to mention before we sort of wrap things up?
The first one would be, as sort of closed chain lower limb biomechanists, which everybody who's interested in doing that effectively is, that trying to get a really good handle on walking and movement in a straight line direction by trying to view gait as efficiently with as much detail as you can, because over the course of multiple years, that the things that you will learn, the ways that you'll be able to understand movement just a lot more from a foot perspective or an ankle perspective or a pressure perspective is going to help dramatically with the ability to converse with the patient. And the patient says, why does my foot hurt? Then if you know something about their leg or their hip or something, the way that they move, that you can sort of tie that in as well, give a comprehensive picture on part of one of the reasons why they might have pain and how you can sort of detect that, but the GP can't, and so on. So I think getting really good at viewing gait and understanding pressure with some technology to do that would be the first one.
Yeah, so it's sort of, if you're going to get tech, that's probably a good place to start rather than diving into POCUS or diving into more of the treatment side of things. It's starting at the point where you're going to gain the most information in the way that we as a profession are probably best suited to fit in. Is that's kind of what you're thinking? That's
exactly what I'd say. Yeah, and I think that everyone sort of wins there. In the clinic, the patient wins because you understand their problem better. You win because you were able to help them and understand, in greater detail what was going on. Maybe there's a new graduate practitioner, and might accelerate their ability to understand all these things and help more people too. So I do think that, and it also does add to the professionalism. Like, even though a lot of people, have to just put up with the iPad in the hallway, obviously there's a lot of value to that, but it really is a whole different thing. And I think trying to say, all we need is an iPad in a hallway, is bullshit, really. Like, it's helpful and it's better than a poke in the eye with a sharp stick. And if it's all you've got, then you're trying your best. But we should be looking to be the absolute professionals in that domain.
And I guess saying just because that's the limit of what you're going to doesn't mean that's the limit that we have to place on everyone else, or it's enough. It contextually might be what you do and you can get good results from, but there is more out there, so don't limit people.
Yeah, certainly. Awesome. Thanks so much for that, Alex.
Yeah, I think it's a great sort of point to end with. Everyone get a Zebris.
It's probably a bit of a one of those things. Once you sort of go there, you probably can't come back. So opens a can of worms.
Yeah, exactly. You just can't deal without my $70,000 treadmill or something. In terms of where people find you, you've enjoyed hearing your thoughts and your opinions and on your experience, really just getting benefit from that. Where would people find you? How can people follow you?
I do a bit on the RunClinic Instagram. Some of the videos are a bit cringy, me just in my lunch break trying to jam out a video, but I do try to make them interesting. And also on LinkedIn, I do like to post the odd case and potentially stir the pot a little bit. But I do really love just chatting shop to anybody, if you didn't notice already. So I'm more than happy to just chat and shoot the shit to anybody, really. So
beautiful. So
easy to find.
LinkedIn Darcy Dore.
Sure. Yeah.
Jump on, talk shit. Perfect. Thanks everyone for tuning into another episode of the Rehab Podiatrist podcast with me, Alex Murray. If you want to follow the podcast or follow me, you can find the Rehab Podiatrist, Facebook, Instagram. I am on LinkedIn as well. That's how I've been chatting with Darcy as well. But until next time, thank you for listening.